Okay.
All
Welcome.
right.
You can go on.
Hi, I'm Dr. Phillip Steele in Helena, Montana. For those of you that ever make it this way, please call me, and would love to have you in my clinic and show you what we're working on. Again, this is a labor of love and lots of influences by Brad. And we'll kind of try to go over what we've been learning about this whole fascial concept and the sonoanatomy of the neck. So this is the C3, C4 facet. I'm doing a side bend. The probe position is actually different than that, but you'll get the idea. And I'm challenging the multifidus here into the facet here. And I'm challenging the fascia layer and the rotaries into the facet of the cervical spine. And so our goal today is really to review the sonoanatomy of the posterior neck. There's like zero literature written about the sonoanatomy of the posterior neck. We're going to talk a little bit about the biotensegrity model of cooperation that Brad's been talking about. We're going to talk about my functional exam to identify pathology. I think ultrasound, the beauty of ultrasound over MRI is the functionality of this. And so I'm really big into coming up with new ways to look at and test the system to see if something's not working correctly. And then I'll talk a little bit about my focused fascial treatments in terms of prolotherapy or regenerative medicine outcomes. The hypothesis that I have is that by understanding the anatomy of the posterior neck, I can have better outcomes. And by targeting in-plane injections to the capsule, the multifidus, and what we'll talk a lot about is called the lateral extension, improves outcome and helps identify areas that need to be treated and focused on. So to kind of go back to Brad's concepts, the fascial continuity of the biotensegrity model prevents any single muscle from acting alone. In the neck, they all have to work together in cooperation of all the neighboring muscles have to all combine on both sides of the neck to assist with muscular movement. And it's the pre-tension in that system that's critical for cooperation. And so we're going to talk a lot about the fascial system of the neck first. So it's confusing in the literature. The literature will say investing fascia, external layer, superficial fascia, superficial lamina. To the most extent, all of that is the same. And highlighted in blue here is this investing layer. So we can see the main muscle here, SCM and trapezius are all part, here's the trap. And then here's the SCM or the sternocleidomastoid, are all part of that superficial layer of the neck. The deep vertebral fascia or the deep layer is this area. And we're going to talk mostly today about the deep layer. So here's our fascial model. Again, the blue here is the deep layer. Notice that it attaches to the transverse processes and the spinous processes all the way around. So this whole layer is in continuity, and this blue line should actually wrap around every single one of these muscles. And then we have in pink or red, we have the investing layer of our fascia. And so SCM, trap, so that's the area that is also part of this system. The problem is really, it's confusing. Anybody that's read these articles, it's sort of confusing to figure out what's what and how this system all works. So based on the literature, I've divided this into a more simple system. I call layer 1 is the trap and SCM. Layer 2 is Splenius Capitis here. And the third layer includes longissimus, Splenius cervicis, levator scap, and longissimus capitis, as well as Semispinalis Capitis. And then deep will be the suboccipitals, as well as the multifidus and the rotaries. An important point, and I want to emphasize this, the Semispinalis cervicis is also in the layer 4. So that's important for later. So layer 4, layer 3 is almost all just Spinalis Capitis. So we'll kind of keep going over that so that it's sort of drilled in by the end of this talk. So as part of that system, Brad mentioned the supraspinal ligament. Well, the continuation of that in the neck is the Ligamentum Nuchae. which is also in the literature also called the dorsal nuchal raphe. And for our purposes today, the nuchal raphe. And what's important is it's really not a ligament. The ligament part of that is not real. It has no ligamentous structure on anatomy or microscopic evaluation. So it's important to realize it's a collection of fibers, mainly from the trapezius and the Splenius Capitis. So it sort of starts at C7 to the occiput, and it is continuous at the supraspinal ligament, but there are some changes in that structure. So we'll talk about that. So here's a special type of MRI with staining for this. This purple line right here is the nuchal raphe. Here's the supraspinal ligament. And all of this investing tissue here is part of the lamella or the septal portion of the nuchal raphe. And this septal portion is what we're going to spend quite a bit of time on. So here on our drawing, this is an important concept here, nuchal raphe, which is a collection of fibers from the trapezius and Splenius Capitis. And then we have the lamellar component or the septal portion, and we'll talk about that area. What's important, and this is a paper that everyone should take a screenshot of this and pull this paper. It's an awesome paper, and talks about it kind of trashes prolotherapy as a treatment option, but the anatomy and the dissection of this portion is worth reading about. And he came to some bad conclusions about prolo, but the concepts are important. So dorsal raphe. Here's the septal portion, and he describes what's called the lateral extension of the nuchal raphe. And this concept is really important. So it's on both sides, and this is part of the pre-tensioning system of the neck. And so here's a Semispinalis Capitis, layer 3, and then deep to that is the multifidus and rotaries, seen in layer 4. And so this layer bridges these two areas, and this is a conduit for nerves, blood vessels, all kinds of structures pass through this layer. But more importantly, it's a major part of the pre-tensioning system of the neck. So this is an abnormal sonogram of the cervical spine in a patient with a whiplash injury with chronic pain. They've had chronic pain for years, and I've sort of simplified it. Here's trap, layer 1. Layer 2, Splenius Capitis. Layer 3 is Semispinalis Capitis. And then multifidus and rotaries in layer 4. And if you can see, this is the nuchal raphe. It's off of midline, and the trap is even asymmetric in terms of its alignment. There's a lot of tension on this side, pulling the whole system to the left here. And then on this side, something's lacks, something's missing. And this green line here sort of represents that there's something broken in this fascial plane, allowing all of this to shift over. And I believe this is the lateral extension that's been torn, and that's allowing this whole structure to shift. So in traditional prolo technique, you're going to come midline and treat many of these structures, but you're not going to identify this area as a way to stabilize the cervical spine. So I do a lot of oblique scanning. Traditional axial scanning or long axis scanning doesn't pick up the fibers that you need. We'll talk a lot about the fact that these fiber directions are critical for your identification sometimes, and to identify layers of injury. But by using an oblique approach, here's the facet. This is all in layer 4. Here's layer 3, layer 2, layer 1. And this is the rotary and the multifidus. And you can see by using an oblique approach, you can see the layering of the multifidus. And if you work at it, you can see it insert into the capsule. So just to briefly describe the Splenius Capitis, again, it's going to gain size. It probably peaks in muscle size about C2, C3. It's described as a large crescent shape, but not always true. And then it'll thin out as you approach the mastoid. What's important to realize is this muscle does move laterally and is lateral to the semispinalis capitis as you go above the C2 level. The Semispinalis Capitis, again, the fibers are all directed almost all vertically, and it's thickest about C2, 3 area as well. And they describe it as the cupped hand sort of look, but on ultrasound, it doesn't always fit that description. But what's important is it has a lot of fibrotendinous component to it. So here's our trap, layer 1, layer 2 is Splenius Cap, layer 3 is Semispinalis Capitis, and you can see all the fibrous component to it. So sometimes the easiest way to identify these is the fibrotendinous component as Semispinalis Capitis can be help you in terms of your sonography evaluation. And then deep, we talked about the fact that this is in layer 4, and you can see on this modeling here that we have, this is Spinalis cervicus, and then you have in that same layer, you have Semispinalis cervicus. It's all part of layer 4. It's in close proximity to the multifidus, and it ends and inserts at this C2. So I talked a little bit about differentiating the rotaries. You'll see that the multifidus typically spanned at least 2 levels. And so your probe angle has to be such that you can pick that up. And so I'm using an oblique approach to scan this area. And then the rotaries are typically more of about a 40-degree angle and a 60-degree angle. And all I'm doing here is sort of rotating the bottom portion of my probe back and forth. There'll be a video clip of that here in a minute to sort of highlight this layer 4, which is frequently injured in these whiplash neck injuries. And the stability of that layer is critical. And that layer 4 and the lateral raphe area, I mean the lateral extension, are important in terms of your evaluation. So what's important is to think about the alignment of the fibers when you're scanning through these areas. If you aren't sure what something is, change your probe angle to mirror these angles, and you can identify the correct muscle type. And so Semispinalis cervicus is very steep angled. Splenius Capitis is heading up to the capitis, and the fiber direction is quite different than the traps or a Semispinalis Capitis. So those angles are important in terms of your evaluation. So I'm constantly moving my probe to sort of help highlight different layers of this system. Now, we briefly talked about the fact that trapezius and Splenius Capitis are really blend into the nuchal raphe, and the Semispinalis Capitis is below that, and the lateral extension is part right here and part there. And so when I have, this is a neutral ultrasound with no pressure, I put pressure on that, I quickly see that this distance separates slightly. So there's some laxity in the trapezius. The Splenius Capitis area seems to be intact, but this area is abnormal. And so I can press up and down with my probe. And then once I've identified this area, frequently I will use Brad's technique of 0.3% lidocaine and 15% dextrose to see what happens. And frequently the patient will talk about the fact that their neck moves better. They have frequently they'll have increased range of motion. That typically with rotation seems better. Side bend is usually better. And I may or may not create a radicular pain pattern when injecting this layer. So we're going to talk a lot about this layer for the remaining portion of the talk, because this area is critical for stability of the neck. It would not be part of a traditional Prolo technique to treat. This is a different patient. Again, a lot of my examples are right-sided, but they can occur left or right. Here's the nuchal raphe. This is a collection of the septal portion, all of this, and trap, layer 1, layer 2, Splenius Capitis, and then we see right here is this muscle sort of balled up and pushing Splenius Capitis up. So this is Semispinalis Capitis here. And with compression, this will slide over and become unstable. So the question is what's hyperlax here? Is it this structure? Is it the septal portion? Is it the pretension from the opposite side? Or is it the same side? So that's the question that we're all trying to answer with this approach. So here's an example. Trap, Splenius Capitis, Semispinalis Capitis, Semispinalis Cervicis is right here, and then multifidus rotaries are down here. So I'm just applying compression back and forth, and I see this asymmetry. What's important to note is with compression, trap stays the same distance here. Trap stays the same. Splenius Capitis, no change in the Splenius Capitis, no change with compression of the Splenius Capitis. If I look right here, I see that the muscle stretches and thins, but it remains attached to the septal portion here. So as I go back and forth, very little movement of this semispinalis capitis is occurring at this level. All the movement seems to be laterally here, okay? And if you look at it, as this pulls away, it pulls this tissue with it. You can see that now. It's pulling that tissue with it. And so the defect is actually not necessarily completely right here, although I end up treating this area. But more importantly, you need to treat this lateral extension. The question is, where's Waldo? I don't know if that expression makes a lot of sense in South America, but where's the pathology? Is it down at the insertion to the facet? Is it in the mid portion, or is it right here? And that's where you'll have to spend more time. And we'll talk about that here in a second. So this is an extreme example. Here's the Nuchal Raphe, clear over here. Here's the spinous process. Here's the bifid component. Trap, layer 1. Layer 2, semispinalis capitis. Layer 3, you can see the septa, fibroconnective tissue, helping you identify its Splenius Capitis. And the fascia is quite thick here. It's very thick compared to the opposite side. And this is an example of the septal component here. It looks like this. Here's the Nuchal Raphe. This is a still shot. And so why in the heck is this whole septal portion pulled completely over here? Well, I would argue that the pretension of the system is intact on this side, and you've ruptured the lateral extension on this side, allowing the whole system to displace towards the right. And you can see even when I do this, this is semispinalis capitis. The muscle actually slips over the top of the spinous process here and creating a snapping sensation. So the crepitation that this patient feels when rotating their neck is related to this whole system being offline. With traditional Prolo technique, where you're going down to bone and going in between, you've missed all of your targets that you normally want to hit. So with sonoanatomy, you're going to identify areas that you didn't realize were a problem. So in this image is a different patient. I'm doing a compression test. I'm seeing that this is very unstable here, but both sides are hyperlax. So traps are stable, Splenius Capitis is stable, but this side's completely released. And you'll actually see bowing. If you look at this carefully, you see bowing of the septal portion laterally. So again, I'm going to want to treat the lateral extension on the lax side, and then treat this fascial component here. Now, frequently I'll do the test with the Prolotherapy, look to see if I improve motion, change headache patterns, and then come back in with a Prolotherapy. When I'm doing Prolo to this area, I typically try to add thrombin to it after I've injected the Prolo to try to form a quicker clot so this stays right where it is. Adipose graft also works quite nicely for these as well. So this is a different example. Here's Nuchal Raphe. I'm actually going to try to follow the lateral extension all the way to the facet. And this is an important part of your scan. So I'm using an oblique view. I used to try to come straight across in the axial plane, but for whatever reason, and certainly be good to get into the cadaver lab to see this, the lateral extension is best identified at about a 40-degree angle, scanning towards the next level down. You'll see the fascia is very thickened in here. It's all thick right here compared to the contralateral side. And as I rotate and follow that fascial plane to the facet, I can see it's intact at the facet. And so my treatment, again, is going to be through this portion. And you can come in from the opposite side and attack that fascial plane. So I'm back to my same patient again. We talked about I'm doing an oblique view to pick up the multifidus off the spinous process before. Here's the facet. And I'm just side bending. I'll put them in flexion and side bend. I'll do a neutral neck position and side bend, and then I'll do an extension and side bend. And so this is all part of my functional assessment. And so I'm looking at the rotaries here, and I see they're not very well developed. This might be a target for platelet releasate to improve muscle development. I could see that the septal portion is fairly thin, and it does not appear to be unstable in this view, but I may want to address it more proximally. And the multifidus, when I pull on that, seems to be intact into the capsule. The capsule component of it seems to be intact on this individual. So the bulk of my treatment is actually going to be to the rotary underneath this area in terms of trying to help stabilize this facet. And so this is sort of my approach to the facet arthritis, is to address the underlying weakness of that area. So the more you start scanning, the more you start realizing that some of these areas will have scar tissue formed. So trap, Splenius Capitis, Semispinalis Capitis. Here's the Nuchal Raphe. You can see that the muscles come together nicely here. Trap on this side is asymmetric. Something's going on. And we have scar tissue here. So there was an old whiplash injury, and this part's all unstable. So I'm going to come in here with Prolo the first time and then PRP towards a later date to try to help resolve this issue. So we're going to try to cover the occiput to T1 here, and we're going to go down the anatomy, trap, Splenius Capitis, Semispinalis Capitis, and then the suboccipitals. So if we go short axis to this plane, we're going to see layer 1. Layer 2 is Splenius Capitis. Remember, the further up you go, the further away Splenius Capitis is from midline. And as you scan, the Semispinalis Capitis gets quite big up here in that C3 through C2 distribution. Here's greater occipital nerve, and this is the fascial plane that we've been talking about. The between 3 and 4 is the critical fascial plane. We have inferior oblique is right here. We're at C2, and then rhomboid major, and we'll kind of go over that anatomy a little more. Here's spinous process. So what's important to know about rectus minor and major, based on cadaver studies and MRI, which I'll show in a minute, the major always lies over minor as you move to C1. Whoops, sorry there. So major is lying over minor, and then here's our Semispinalis Capitis. Here's our nerve highway. I'm just going to throw one extra slide in here because I love nerves. Everybody knows I like to nerve. This is the greater occipital nerve piercing through the Semispinalis Capitis. So that's the nerve. And so when you treat greater occipital nerve headaches, you need to open this up. There's where the entrapment is. Everybody else is sort of teaching you to inject down here. The problem is here as it moves through the Semispinalis Capitis, and it takes a 180-degree corner, which is part of to help accommodate turning your head, but it also is part of the problem. So I'm not going to spend much time on nerves, but here we are, long axis, short axis view, rectus minor, you just saw this, rectus major lying over the top, Semispinalis Capitis. Here's my long axis view, rectus minor inserting into C1, rectus major into C2. And this becomes important. Here's our neurovascular area in the fascia between 3 and 4. And because we can see there's a mild dural bridge down here, which is a frequent cause of headaches. So here I am approximately right about here. Here's rectus minor. And I'm actually slid a little further over. So this shadow right here is actually the rectus major. But as I'm in the midline, this fascial plane separates Semispinalis Capitis. And important that this right here is the posterior atlanto-occipital membrane and spinal cords down here. So if you're going to play around here, you better have really strong power Doppler, color flow Doppler skills, as well as very, very good needle skills. So rectus minor, rectus major, you've seen I've slid over a little bit, and I'm straight on top here, Semispinalis Capitis, and you can see rectus major inserting into 2 and rectus minor inserting into 1. And what's important about this is with chronic whiplash injuries, atrophy of these muscles can occur. And so here's another patient, rectus minor, but it's hard to tell what's happening here. And many of the patients I see, the muscle development here is hard to identify as it inserts into one, because it becomes tendinous in some people where the muscle is more prominent in others. Here's rectus major. Here's our neurovascular bone, semispinalis, and trap. So what's important here is that this relationship of major and minor is almost always holds true. Even as you scan further up, rectus minor will pull off to the side. But this relationship in here, in these muscles, you can start to measure the muscle size. And so I'll frequently do a circumferential measurement of rectus minor and major on both sides to screen for atrophy. You can do a short axis through the muscle as well. Here's my view. Layer. This is my fascial layer separating 3 from 4. Here's C1, and then this is rectus capitis minor. Here's major lying over the top, and here's inferior oblique. So I'll routinely measure the muscle mass here for people with chronic neck pain to help guide my therapy down the road. And again, this is a dangerous area to play in if you don't have the skills. So article that just sort of rocked my world was this article looking at suboccipital muscle atrophy is associated with not only a mild traumatic brain injury, but also chronic whiplash injuries. And so that's what started me down the path of making these measurements. And so then I decided, well, geez, I can make these measurements, but is the muscle really intact? So here I am doing a functional evaluation of these muscles. So I'm going to take my patient through a flexion and extension. I have a curvilinear probe here. And what appears to be that when I go into flexion, this muscle, you can see it has normal tension through here. And when I go into extension, it sort of balls up, which would be a normal, healthy muscle, because it's having a normal reaction to stress and relaxation. And the same goes through with my rectus capitis major. And so from a functional exam standpoint, I use muscle mass and functional evaluation to look for stability of these muscles. If you slide directly over the spinous process, here's C2, here's C3, here's C4. You can then pick up the interspinalis cervicis, which are these. And this is a common area that you're treating with traditional Prolo technique, but your ability to guide and identify areas that are unstable from a chronic whiplash injury is improved by utilizing this. And more importantly, is you can see this, the semispinalis cervicis insertion into C2. And this is where your functional exam can play into that as well. So you can do flexion extension to look at this particular muscle attachment, compare left versus right, look for atrophy, and then identify the pathology and make enhancements in your Prolo technique. You can also use an oblique approach. This is the C1. This is C2. Here's the spinous process of C2. Here's the transverse process C1. And I'll compare left versus right inferior oblique. So this inferior oblique here is important in terms of the rotary mobility and stability of the neck. And so if you see atrophy of this on one side compared to the next, and I even do some rotational examples to look for the integrity of this muscle, that's all an important part of your evaluation. Now, this transverse process is, lots of landmines here. So you better be good with your color flow and power Doppler. But you can start to identify all these targets that come into this area that create pain right here. So here's my inferior oblique. You'll see I have a large red dot here. This is where the blood vessel lives and artery lives. And you can start to see different shadows in here that make up a bunch of different muscles that include in here. So we'll go over that here with a better image. So That triangle area that I just showed you of the C1 was really difficult for me to figure out. And so then one day I'm scanning for any help. If you Google or use whatever search engine you want, MRI sliced image through that area, there's no literature out there. What's interesting is this one article is out there, and it shows all the muscle attachments they've highlighted. And it's an amazing piece for your library. I would encourage everyone to pull this article, screenshot this, and pull this article for your own library, because it's invaluable in terms of identifying all of these specific muscles. So you can see right here is a little confusing. This, and I make a note here because they're calling this Spinalis Capitis, but in the literature it's called Spinalis cervicis, because in the literature everyone seems to say that this muscle inserts into C2 or C1, but in reality on this MRI study, and they make a point of this, we'll talk just briefly about this, but the phone apps or iPad apps we have are incorrect in this area. So Semispinalis Capitis, Splenius Capitis, and then they go slice by slice by slice down the neck. So trap, Semispinalis Capitis, Rectus Capitis posterior. Remember when I said the relationship is that muscle is always superficial to the deeper Rectus Capitis minor. And then here's superior oblique at C1. You get down to 2, we start seeing the emergence of inferior oblique. We see the elimination of the rectus minor, and now we only see Rectus Capitis posterior. So you can use this anatomy, MRI anatomy, to help you with your ultrasound capabilities. And so I use this back and forth. I would pull this slide up, go through back and forth. I would scan that level and be able to identify all these topics. And so once I could identify all the muscles, I would go down to the next level. And so I just gradually, bit by bit by bit, learned what all these structures were on ultrasound. So we're going to go back to that devil's triangle here. You can now, once you've used your MRI anatomy to help you correlate, you can put this on C1. I'm sort of, here's inferior oblique, which is right here. I have a superior oblique, which is taking off right there. Here's off of C1. So these two will come in together. I have Longissimus Capitis right here. And what's interesting is the phone app, or the anatomy app I have, actually has this incorrect. They're showing it going underneath this muscle right here is longissimus. They show it going underneath these, and in reality, it goes over. Some anatomy apps have this correct, but it's important to understand that relationship. And then here's Rectus Capitis major coming in over here underneath these other structures. So by using those MRI anatomy slides, you can start to differentiate things. So I keep talking about it's important to be able to identify fiber types. Here's rotary and here's multifidus, and so here's multifidus, and then this little, that's, if you're below C2, that's Semispinalis Capitis, and then here's your fascial layer. So by using this technique of where I'm just sort of dialing the bottom end of my probe, I can highlight different layers. I can see Semispinalis Capitis, Splenius Capitis, trap. And so that's an important technique to learn to help identify. So we can keep going down. I'm not going to belabor all of this with going through each one of these. This you can do on your own time. This is, again, I would pull this article. It's incredibly valuable. There's very little written about these relationships and how to identify pathology here. This is a journey well worth learning. It takes some time. I came in on a lot of weekends and scanned a lot of necks to try to identify that, but you'll start noticing scar tissue formations, all kinds of things as part of chronic pain, and you can identify pathology that you just were completely unaware of and would not normally address in terms of a normal Prolo technique. So we'll keep going down to 6, 7. Here's a slide that you can use. It's important. Remember, I said the semispinalis cervicis is thickest towards the bottom. At C7, it takes up the majority of the fourth layer. So, and then look how small semispinalis capitis is here. And Splenius Capitis is quite large down here. So these relationships you can confirm on your MRI correlate, and that put your probe on these areas and then learn to identify all the different targets. Remember, again, I said that the Semispinalis Capitis has lots of fibroconnective areas, so that helps differentiate Semispinalis cervicus from Capitus. So that's a key element. Down to T1, and it was faster than I thought. So in summary, developing a better understanding of the posterior neck sonoanatomy can improve your outcomes and identify pathology you just weren't aware existed. More importantly, it allows you to treat the lateral extension of the septal portion of the nuchal raphe. And by identifying laxities in the pre-tension of the neck, you improve communication, improve the biotensegrity model, improve motion, decrease pain, and hopefully get your patients back on the road to recovery. If you have questions, feel free to email me, certainly this is a journey in terms of learning this anatomy. You'll have to spend some time in the lab to learn all these structures on ultrasound. But if once you learn the functional component and learn the other aspects of the scanning in this region in terms of the different fascial layers, it can really improve your patient's care. So hopefully there's a little time for some questions. Again, being able to scan this area from a functional standpoint and looking at these facets under movement, it gives you an advantage over traditional MRI. And so spend the time learning the MRI correlates and then apply this to ultrasound, and it will change how you practice medicine. So I think that's the end of what I have. Presenting. All right. Any questions?
Hey, Dr. Phillip. I think there's no questions here, but I want to thank you very much for your presentation. There's a lot of new information for us. We're going to have to spend a lot of time learning what you told us, but it was really amazing, all this new side anatomy from the posterior neck. Thank you very much.
You're welcome.
Hi, Steele. Nice to see you. Thank you very much for your presentation. Very nice to show this presentation. The last time was amazing. What a shame that we can't see you again in Cusco. But thank you very much for joining us.
Oh, thank you.
Hello, Professor Phillip. Thank you very much for your presentation. It was very interesting.
Any more questions? I think that's it.